Now, good morning everybody, and welcome to the second of our series of hearings examining the use of lockdown and other non-pharmaceutical measures as tools governments can consider when facing a public health emergency such as COVID-19. Our focus today and tomorrow is on the scientific considerations that could or should be taken into account by governments considering implementing such restrictions. I'd like to welcome our expert witnesses who have particular professional expertise in the fields of epidemiology and public health, and thank them all for agreeing to participate in what I'm sure will be a very interesting discussion. They will introduce themselves shortly. I now invite Inquiry Counsel, David Turner, King's Counsel, to make an opening statement, in the course of which he will set out the timings for the submission of any Rule 9 requests that arise over the course of today and tomorrow. And as in the past, I would ask all legal representatives to take note of the timings and adhere to them assiduously. Thank you very much. Mr. Turner.
Thank you, my Lord, and good morning. I'm assisted, my Lord, today by my learned friend, Mr. Chris Stephen, Advocate. As your Lordship has indicated, today and tomorrow, the inquiry will hear evidence of the scientific knowledge and considerations that could or should be applied before making decisions, such as locking down or imposing other restrictions. For present purposes, we shall refer to these as the scientific considerations. This is the second in the trilogy of roundtable hearings. The first of these took place last week. Your Lordship heard from two international experts on the different approaches taken in Sweden and New Zealand to limit the spread of COVID-19. The series will complete later this week with a panel discussion discussing the social and ethical considerations of restrictions. If I may say, the second in a trilogy is often the best. As in The Godfather Part 2, it provides the space to present alternative plot lines and allow a deeper understanding. With that in mind, and without your Lordship making any offers that they could not refuse, we are joined today by four preeminent experts in epidemiology and public health. I will allow each of them to say more about themselves shortly, but by way of brief introduction, we have with us, first of all, Professor David Heyman, Professor of Infectious Disease Epidemiology at the London School of Tropical Medicine, Professor Sunetra Gupta, Professor of Theoretical Epidemiology of the University of Oxford, Professor Mark Woolhouse, Professor of Infectious Disease Epidemiology at the University of Edinburgh, and Professor Claire Bamborough, Professor of Public Health, Newcastle University. Each of the witnesses is appearing before the inquiry as an expert in their respective fields. Given that those fields vary, it is not expected that each of the witnesses will be able to speak to every matter raised for discussion. The witnesses have each been advised of their duties as experts, that they are to provide their unbiased opinions as independent witnesses in relation to the matters that they are within their expertise. It should be acknowledged and understood that the evidence heard from these witnesses is and will remain these experts' respective professional opinions. They are not asked to reach any particular consensus. The appearance of any witnesses should not be taken as an endorsement or a rejection by the inquiry of any particular view or position. Ultimately, in the inquiry, the weight to be attached to these experts' evidence and any conclusions to be drawn therefrom remains solely matters for your Lordship to reach in light of all the evidence gathered or otherwise available to the inquiry. In this last regard, core participants are reminded that the inquiry and the UK COVID-19 inquiry have taken steps to avoid duplication. Engineering and other scientific evidence gathered by the UKI will be available for your Lordship's consideration. Each of today's panel has provided the inquiry with a written response to questions posed by the inquiry. The references for those responses are, in respect of Professor Gupta, SCI RT22, in respect of Professor Heyman, SCI RTR2, in respect of Professor Bamborough, SCI RTR1, and in respect of Professor Woolhouse, SCI RT23. These written responses were published on the inquiry website today. A brief word, if I may, about the format of the hearing. This will be in the form of a roundtable discussion. I'm hopeful that our slightly revised seating arrangements will allow participants to be able to interact freely. My role is primarily to facilitate that discussion, and whilst I'll pose a series of questions to one or more of the panel members, the other members of the panel are invited to contribute and discuss any points that they feel your Lordship may wish to consider. If there's any matter that you wish to come in upon, please do just raise your hand or otherwise indicate that you wish to be brought in. Where helpful to your Lordship's understanding, I would welcome direct discussion between the panel members. I just ask that you be mindful to speak into the microphone. Even if I can hear you, the stenographers or remote viewers may not be able to. And please not to speak over each other to allow for proper transcription. In that last regard, I'll also ask if you can try to speak slowly and clearly. My learned junior will no doubt tell me if you or I fail to adhere to that request. With respect to the parameters of the evidence, earlier in the series, your Lordship explained the focused nature and purpose of the present series. However, I think it bears repeating this morning. Whilst your Lordship is keen to understand considerations that shaped the real-world policy at the time of the pandemic, these hearings are not intended to critically assess any particular approach taken by the Scottish Government during the pandemic. Such matters will be explored during the inquiry's implementation and decision-making hearings and are therefore, strictly speaking, out of scope for these sessions. Core participants and their legal representatives are asked to bear that in mind in particular when considering making any Rule 9 applications. In terms of the Rule 9 procedures themselves, Rule 9 of the Inquiry Scotland Act 2007 makes provision for a core participant or a recognised legal representative of a core participant to apply to the Chair for permission to examine any witness giving oral evidence. In accordance with your Lordship's procedural powers under Section 17 of the 2005 Act, your Lordship has directed a particular procedure be followed in making any applications in terms of Rule 9. The current direction is dated the 8th of September 2025 and may be found on the inquiry website. This procedure supplements and is in addition to any requirements set out in Rule 9. The procedure is intended to fairly facilitate any relevant questions from core participants whilst allowing the inquiry to manage its time and resources effectively. Failure on the part of core participants to adhere to the requirements of the rules or of the supplemental procedure interferes with the ability of the inquiry to undertake its work and may result in questions being rejected. In respect of the scientific considerations hearings alone, the inquiry has already received in excess of 300 questions from core participants. A significant proportion of these questions were not within the scope of the present hearings. Core participants are asked to please note the following. Firstly, questions and topics should be proposed at the earliest opportunity, in particular during the course of any hearing. As a corollary, it is expected that any questions arising today will be submitted this evening at the latest. Secondly, to allow consideration of any Rule 9 applications relating to matters arising new in the final morning of this hearing, that's tomorrow, Tuesday the 30th of September, these must be submitted by 12:30 p.m. that day. Thirdly, questions submitted during the course of the hearing are expected to relate to information that has arisen during the course of these witnesses' evidence that is material, relevant and new. In these regards, please note in particular with reference to Rule 9.5 that an explanation must be provided as to whether the examination will raise new matters or issues. And under paragraph 6.1 of the supplemental procedure, the Chair requires that an explanation be given as to why the question could not have been submitted in advance of the hearing. Fourthly, core participants' legal representatives should always consider whether the question is within the scope of these hearings as previously described. Out-of-scope questions may be rejected by your Lordship. And finally, core participants, please note that I shall not recommend to your Lordship to allow examination in respect of matters or issues that are not necessary for the inquiry to fulfil its terms of reference, in particular, due to lack of novelty, relevance or materiality. I would not expect core participants to propose such matters or issues. If I can now mention a few matters relating to the timing of these scientific consideration hearings. With respect to the timetable, the hearing will take place today and tomorrow. The start, finish and lunch break times have been published on the inquiry website. Today we will break for lunch at 12:30 and finish around 4:15 p.m. And tomorrow we will commence the hearing at 9:30 a.m, break for lunch at 12 noon and finish no later than 4:30 p.m. To assist our stenographers in the mid-morning and in the afternoon, we shall take a 15-minute break, and that will occur after 1 hour and 15 minutes has elapsed. The mathematically minded will have gathered from this approach that we will have 8 sessions available over these 2 days, and it is my intention that we shall use the first 6 of these sessions for questions devised or accepted by counsel to the inquiry. The final 2 sessions tomorrow afternoon will be reserved for any remaining questions submitted under the inquiry's Rule 9 procedures. The final matter I wish to address is the question of opening and closing statements. In terms of your Lordship's direction of the 24th of September 2025, core participants are not being invited to make opening statements in these hearings. Core participants may, if they wish, submit a written closing statement to the inquiry. Written statements are to be submitted by no later than 12 noon on the 14th of November 2025. The formal requirements for closing statements are set out in the direction. The formalities of those may differ from previous closing statement directions. It should be noted that His Lordship's direction does not require core participants to make a closing statement, and the decision whether to do so or not is entirely one for each core participant. Core participants should only do so insofar as they consider it is appropriate and helpful to the inquiry. My Lord, that concludes my opening remarks.
Very good. Thank you very much. May I proceed?
Thank you, my Lord. Good morning again. Firstly, may I just welcome you to today's hearing. Thank you for your participation in the inquiry to date. As I noted in opening, each of you have spent considerable time responding in writing to the inquiry already. However, we are delighted that you could join us in person to discuss the scientific considerations of lockdown and other restrictions. I said that I would give each of you an opportunity to introduce yourself, and the time for that has now come. If I could start perhaps with Professor Gupta. Could you please tell us your name, your occupation, including where you're currently working, and your areas of specialism and expertise relevant to the current hearing?
Thank you very much for asking me to participate. I hope I'm loud enough here. So I am Sunetra Gupta. I am Professor of Theoretical Epidemiology in the Department of Biology at the University of Oxford. My expertise, as my title would suggest, is primarily in using mathematical models to understand the transmission of infectious diseases and also the evolution of the organisms involved, the pathogens and what we call the hosts, as in us. However, in the last decade or so, or really maybe a bit longer, my focus has actually been more on translating some of my findings from the work I've done, particularly on understanding how pathogen diversity evolves, applying that to developing a new vaccine for influenza, which has taken me out of my original sort of comfort zone into the lab and has permitted me to spend a lot of time learning about immunology, vaccinology, and indeed designing vaccines and doing the necessary experiments to test them. So why am I saying this? Because obviously title theoretical epidemiology could lead one to almost dismiss some of my some of what I'm saying as coming from someone who doesn't have much practical experience, but I do have a lot of practical experience now in the lab, and also to a much smaller degree in the field, as I've always collaborated with field epidemiologists throughout my career. Thank you very much.
Thank you. And in addition to your academic work, are you a member of any particular groups or organisations?
No, not really.
We'll touch upon your substantive experience during the pandemic, but in very general terms, can you give His Lordship an overview of what you were doing during the pandemic?
During the pandemic, I felt I was motivated, I would say, primarily by concerns which are not necessarily in my area of expertise, in that my main concern was the economic conditions under which much of the world has to exist. So I come from India, and the global south has always been a big a concern for me, and how achieving a situation where I'm an internationalist. I mean, I don't belong to any particular political group, but I am an internationalist, and I guess you could describe my politics as, if that's of any relevance, as being left-leaning. So international socialism has been a core of what I like to think of as informing my attitudes to the pandemic. Now, obviously, but in this particular case, I felt that I had the expertise to suggest interventions that might lead to what I considered to be a global solution that was more acceptable to me than what was being proposed. So during the pandemic, I was vocal against lockdowns, broadly speaking, and my main motivation was really the effects on the global south. However, I did also feel that because of my knowledge, my professional knowledge in that area, that I was in a position to make judgments about what was happening, and that it was my duty to present my opinions. And so there were various routes taken that I took to try and achieve that, many of which were thwarted and caused it to be a very uncomfortable time for me.
Thank you. You mentioned in your statement that you were a founder, member and trustee of Collateral Global. Mm-hmm. Could you tell us about that?
So Collateral Global was a charity that was set up to document the harms of lockdown in primarily the global south, because that seemed to be missing from the discussions that were being carried out. It has so far done well. It has followed that line of inquiry in terms of trying to raise money to fund projects in the global south. Our success has obviously perforce been modest. We've produced a few films, and we intend to produce some more. For example, looking at what happened to children in India, etc. actually, what we have decided now is actually, rather than it having an academic focus, the best way forwards, because I do actually feel that in approaching what happened, we need to think of it beyond just a scientific exercise. And I know we're sitting here discussing that, but I see what should happen now as also being largely a historical exercise in the true sort of sense of what history means. So we are thinking, our intention now is to turn Collateral Global into a museum of lockdown, in a sort of Walter Benjamin sense of a museum, or sense of history, maybe a Borgesian sense of a museum, but where, what happened is documented and responded to and recorded in a more mature way than simply saying, oh, so-and-so shouldn't have sent a WhatsApp message to so-and-so saying this. We really need to look at what happened. It was a massive social experiment, and it needs to be approached both scientifically and through the lens of, proper historical and, dare I say it, artistic perspectives. So sorry if I'm already straying from, but my feelings about what happened and what should happen is that we need to have a more multidimensional, mature and nuanced approach.
Thank you. Just one final matter here. If you could just confirm for me, you have provided previously a statement to the UK inquiry, is that correct? And our inquiry has received a copy of that. Could I ask, were you asked to give evidence by the UK? Aye.
I was not invited to defend my position, and instead points that I'd raised were put to other people to comment on, and some very glibly said, we considered those issues and decided that wouldn't work. For example, was it possible to protect the more vulnerable? This is very distressing to me, and I think I imagine that there are reasons to believe that it was procedurally incorrect.
Thank you. Thank you, Professor Gupta. Professor Bambra, could I come to you next? Could you tell us your name, again, your occupation, where you're currently working, and your areas of specialism and expertise relevant to today's hearing?
Certainly, thank you. I'm Claire Bambra. I'm Professor of Public Health at Newcastle University, and my areas of expertise are in health inequalities, and my background is as a social scientist. During the COVID-19 period, a lot of my work is funded by National Institute of Health and Social Care Research, and we were asked by them, wherever possible, to try and refocus our time and efforts into COVID-related work in our areas of expertise. So during this period, together with other colleagues, particularly in the north of England, we started looking at some of the inequalities aspects and published a series of reports and articles around that, funded by NIHR and also funded by the Health Foundation. Since then, I have been an independent expert witness commissioned by the UK inquiry to produce a report for them, together with Professor Sir Michael Marmot for Module 1, looking at health inequalities in the lead-up to the pandemic. And I'm currently working on, with Michael again, a report for Module 10 of the UK inquiry, which is looking at certain aspects of inequalities during the pandemic period, so roughly 2020 to 2023. And I believe that you have access to both of those.
We do. Thank you. You listed within your written statement to the inquiry a number of organisations that you're involved with. Could you tell us about some of those?
Yes, I can just check what you mean. Do you mean like the Academy of Medical Sciences?
For example,
yes. Yeah, okay, yes. So I'm a fellow of the Academy of Medical Sciences. So obviously that's the learned society. And I'm an honorary fellow of the Faculty of Public Health, a fellow of the Academy of Social Sciences, and I was also elected to be part of the German Academy of Sciences. So these are just sort of positions based on your scientific expertise. They're just academic groups in effect.
Thank you. Professor Heyman, if I could come to you next. Could you please tell us your full name, again, occupation, where you're currently working, your areas of specialism, and any background expertise relevant to the current hearing?
Thank you. I'm David Heyman, and I'm a medical doctor and a field epidemiologist. I'm currently a professor of infectious disease epidemiology at the London School of Hygiene and Tropical Medicine. My career was with the United States Centers for Disease Control. First 2 years in India working with colleagues on smallpox eradication, then beginning in Africa in 1976 with the first Ebola outbreak, staying on 13 years in sub-Saharan Africa, and after that being seconded to the World Health Organization in Geneva. At the World Health Organization, I headed the infectious disease group of programs and was responsible for leading the outbreak to SARS-1 in 2003. After that, I retired from the CDC and WHO and took a position as chair of Public Health England, first of all as Health Protection Agency, which then became Public Health England. And in 2017, I went full-time to the School of Tropical Medicine. During the COVID pandemic, I was chairman of the advisory group to the emergencies program at WHO. During that period, we met weekly for the first year and a half, and then after that, as required by WHO, listening to what was going on from programs in countries throughout the world. At the same time, I worked informally with the Chief Medical Officer and his team here in UK, reporting what was going on at WHO and in the world. At the same time, after that, I participated in the inquiry, in the UK inquiry, in Module 1, and I also participated in an inquiry in Wales, and currently I'm participating in an inquiry in Ireland. I've had much experience in infectious diseases, both in the field and in the area of making policies. Thank you.
Thank you. And again, you mentioned your involvement there with the UK inquiry. You provided a statement to them, and you mentioned you've given evidence as well, and we have access to both of those. Last but not least, Professor Woolhouse, could you please tell us your name, occupation, your full name, your occupation, where you're currently working, and again, your specialism and expertise relevant to the current hearing?
Yes, thank you. I'm Mark Woolhouse. I'm Professor of Infectious Disease Epidemiology at the University of Edinburgh. Been in Edinburgh since 1997. I'm a researcher in epidemiology, that is the spread, the transmission and spread of infectious diseases, but over the last decade or so, my area of interest has broadened out into the entire context of the health systems in which we try to manage epidemics and pandemics. We did a lot of work also on the origins of new pathogens, novel pathogens, and if I'm allowed to say I have a claim to fame at all, one of them is the co-creator of the concept of disease X, which you will have heard about, which was conceived in a basement much like this in Geneva in the winter of 2017 in a meeting of a WHO advisory group on emerging pathogens. I have worked prior to the COVID pandemic as an advisor to government in the UK, particularly DEFRA and the Food Standards Agency, part of their advisory boards, and also to the World Health Organization in various ad hoc contexts, including the one that I just mentioned. I am a fellow of the Royal Society of Edinburgh, of the Academy of Medical Sciences, and also the African Academy of Sciences. The latter reflects my interests in global health, which I've held for many years now. And one of the things that I was very much involved in during the pandemic was in advising World Health Organization in Africa region on aspects to do with pandemic intelligence and analysis of data and interpretation of data as well. So we did a lot of work with them. Fully endorse what my colleague Shanitra Gupta just said about the global aspect of the importance of lockdown. I don't know how narrowly my Lord wants to focus this part on, maybe it's just Scotland, but I think the subject that we're discussing is extremely relevant to the global south, where I think some of the problems encountered were considerably greater even than we experienced in Scotland. And as an expression of interest on that, we do actually have put together a team that wants to do further research on the impact of the pandemic on Africa. Here in the UK, I was a founding member of the Scottish Government's COVID-19 Advisory Group, which was formed in March 2020. I might come back to that date later, I suppose. In January 2020, 2 months earlier, I was co-opted onto one of the subgroups of SAGE, the leading advisory group for the UK government, and the subgroup was called SPI-MO, which is to do with epidemiological modelling in the context of COVID-19. And I worked with that for over 2 years until March 2020. Back in Scotland, I was also one of the original members of the Scottish Government Standing Committee on Pandemic Preparedness, which is supposed to be forward-thinking, but I actually resigned from that last month, so I'm no longer a member of that group, which is an update to my statement here. And you were asking about appearances before the UK COVID inquiry. So I've given them 5 witness statements. I've made 3 appearances before them for modules 1, modules 2, and here in Edinburgh, module 2A. And they also wanted a witness statement for module 7 as well from me for that. On that note, I think I'm not alone in this. I've also appeared before half a dozen select committees, both in Westminster and Holyrood. I think, David, you've done the same sort of job as well. And to cap that off, I wrote a book about the whole experience as well, published in 2020. The title was The Year the World Went Mad, which maybe gives a bit of a clue of what I thought about events as they unfolded in 2020 and 2021.
Thank you. Thank you all. I'd like to begin, if I may, talking about some generalities. The inquiry is tasked with establishing the facts of and learning lessons from the strategic response to the pandemic. We're here to talk today about the scientific considerations of lockdown and other restrictions. But to put that in context, I'd like to talk briefly about the meaning and understanding of some of the terminology that we might be using. First of all, in the context of a pandemic, we're aware, of course, that the COVID-19 outbreak was declared a pandemic. The first thing I'd like to understand is what, if anything, is the significance of looking at these matters in the context of a pandemic as opposed to an outbreak, an infectious outbreak, more limited. Professor Woolhouse, perhaps I could come to you first. From an epidemiological perspective and infection control, is this just a question of degree, or is there more significance to this being a pandemic as opposed to an infection outbreak?
Well, thank you for coming to me first, but I think in the end I'm going to end up deferring to David's view on this, since he worked on this exact topic for some time. David, do you want to explain the international health regulations?
I was fearful that Professor Heyman may exhaust this topic before anyone else had a chance to go. But Professor Heyman, if you want to take the floor.
Thank you, thank you, Mark. It's a very important concept to understand, an emerging infection, which is what's at the source of many of the outbreaks and pandemics that we see today. And an emerging infection is an organism that is identified for the first time in human populations. That doesn't mean it's identified when it occurred. It may have occurred 20 years previously, but was unrecognized, and then 20 years later is recognized in humans, such as HIV, which was in humans many years before it was recognized. Once this occurs, once an organism passes over the barrier between animals and infects humans, there are generally 3 potential pathways of causing an epidemic or a pandemic. The first is a simple crossing of the barrier between humans and animals and causing an infection in humans that doesn't spread further. Rabies is a good example. The second is an infection which comes from an animal into a human, causes an outbreak, but doesn't establish itself permanently in human populations. Good examples are Ebola, are avian influenza, bird flu, which come from the animal kingdom to humans, cause outbreaks, but then reemerge at a later time after they've disappeared. And then the third is one that enters human populations, remains in human populations, and becomes endemic with humans long term. The classic example of this recently is HIV, which is thought to have emerged from the animal kingdom sometime in the early 20th century, but was not recognized until the 1980s. And then the current COVID-19 is also an example of a disease which emerged, which caused outbreaks, and is now endemic in human populations, as are 4 other human coronaviruses. So this is the background for outbreaks. Whether or not it's a pandemic is not known at the start. That's why it's very important at the start to do everything possible to stop it from spreading further if this is possible. It's very possible with some routes of transmission, such as water, such as body fluids, but it's very difficult with a respiratory infection and mainly impossible with infectious diseases such as influenza or COVID-19.
Thank you. And you said it's not possible to determine initially into which category a new pathogen or emerging infection falls. At what stage would it become possible? Would one anticipate?
It becomes possible once the efforts have made with non-pharmaceutical interventions to stop it, to see whether or not it can be stopped. SARS coronavirus 1 was stopped by non-pharmaceutical interventions, but also by the fact that it was not as easy to transmit this infection from person to person as was SARS coronavirus 2.
Thank you. We're referring to non-pharmaceutical interventions. So we have non-pharmaceutical and we have pharmaceutical interventions. With respect to an emerging infection, which or are both of those available?
At the time of emergence, many times it's only the non-pharmaceutical interventions that are important. And what's extremely important to understand in emerging infections is that infection prevention and control in health facilities is one of the major factors in determining whether or not there will be even an outbreak. Because what happens is that the health workers, not suspecting an emerging infection because it appears like other infections, don't take the same precautions that they would take if they knew that it was a new and emerging infection. This happens. They become infected, they then transmit it, unfortunately, within the health facilities from health worker to patient, or from patient to patient by improper sterilization of tools used in the hospital, and then it amplifies transmission into an epidemic. If this continues at many sites, the epidemic spreads rapidly, and if it's a respiratory infection in particular, then it can spread extremely rapidly. But it always begins with, it usually begins with health workers becoming infected because they're unaware that this is occurring. This has happened in many outbreaks throughout history, including with SARS coronavirus 2 and 1.
You're discussing there interventions by non-pharmaceutical means, particularly the initial stages of an infection outbreak. Could you describe for us very broadly what are the options for non-pharmaceutical interventions that we're discussing?
Well, one is infection prevention and control, which is very important. The second is contact tracing, identifying persons who are sick, isolating them as best possible, and then following those persons who were in contact with that person for a period of time during the period of incubation to see whether or not they develop a fever or any symptoms of this infection, and they then become isolated and their contacts traced. That's a very powerful tool in outbreaks, especially those that aren't transmitted by respiratory means. Those by respiratory means, if it's by droplets, by face-to-face contact, it's fairly easy to identify those patients, isolate them, and isolate the contacts who become sick. But if it's one that spreads by airborne transmission, finer droplets, such as in COVID-19 or influenza, very, very difficult to do contact tracing and have any real effect on stopping transmission, although transmission can be decreased greatly, as was done in Asian countries where they investigated outbreaks, shut down where transmission was occurring for SARS coronavirus 2, and were able to slow the entry of the virus into their countries.
You've touched upon it very briefly there, but can I ask you directly, what are the principal aims of infection control?
The aims of infection control are to prevent health workers from becoming infected and from preventing instruments used in the hospital or the actual health workers from transmitting infection from one person to another. Some examples of how this happens were in Ebola outbreaks where needles and syringes were not properly sterilized, and in many, many other types of infections. Another good example is mad cow disease, where transmission occurred not because of poor infection prevention and control, but because of slaughtering practices which permitted infectious material to infect the meat and other parts of the animal from the central nervous system where the infectious agent was contained.
We've heard evidence of terms such as suppression and elimination. Could you explain your understanding of those concepts?
Yes, these concepts are often used differently by different epidemiologists and different persons. Suppression is to decrease the transmission level, and elimination is to stop the transmission at one point, but not throughout. In other words, you can stop transmission possibly in one area, but then must continue those efforts because it's present in other areas and could enter. And then the final step is eradication, which interrupts transmission completely. And for that, one must have solid herd immunity. One must have prevention of infection of a person by either a vaccine or by a previous infection, which stops transmission, which protects that person against infection so they can't become infected and transfer the virus or bacterium to others.
Are there any examples of eradication of a pathogen historically?
There are two examples of complete eradication of an organism. One is smallpox, which was eradicated and declared eradicated in 1980, and the second is rinderpest in cattle. Rinderpest was a disease which emaciated cattle and caused food shortages throughout Europe and many parts of the world in the early 20th century. With a vaccine, protection of all the cattle who were at risk of infection, the disease has now been eradicated. However, the organisms that cause these diseases are still maintained in laboratories. If they're eliminated from those laboratories, then the disease will have become extinct, and it will be extinction.
Does it follow from that, and indeed the endemic nature of a lot of these pathogens, that the highest aspiration would be elimination rather than eradication?
It certainly depends on the organism. In an organism, in terms of eradication, such as SARS coronavirus 2, COVID-19, eradication would not be possible because there's not a vaccine at present that stops infecting, that completely protects all humans against infection. And even those humans who are protected against serious illness, there's carriage of the virus many times in the nasal passage. And so a vaccine that could stop that nasal passage presence of virus could, in effect, and protect against infection, could cause eradication, but that is not yet available.
Thank you. I'll give you a rest, Professor Heyman, if I may. I'd like to talk to you now about something which the inquiry has heard about before, and it may be a topic that you have different views, and I'll perhaps come round the table about this, but the inquiry has heard evidence regarding a concept known as the precautionary principle. In particular, it's been suggested that the precautionary principle might be a legal one rather than one used in epidemiology. Professor Woolhouse, could I perhaps come to you first? Is the precautionary principle something that's used in epidemiology?
It's not something you would find written up in the public health textbooks as such. I think it's more of a social construct than an epidemiological one, which is how you use evidence to guide your actions. That's what it's trying to get at. I'm distracted because I want to add one or two things to what David said.
we can come back to that in a moment, Professor. But perhaps could I
So,
at this point could I ask you? What do you understand the principle to be?
Better safe than sorry. Simple as that. That's how I understand it and how I use it in my writings.
And in practice, how would that manifest?
In practice, what it can manifest to is an extremely high level of risk aversion. The difficulty is that if you're faced with a situation where the risks are essentially unknown, such as how many people are going to be infected by an emerging infection of the sort that David described, how many will get sick, how many will die, how is it transmitted, which, as David said, is extremely important. If those are all unknowns, it is possible for anyone to claim, on the basis of basically no evidence at all, that, well, it could be very serious. It could transmit this way. It could affect these people. It could affect children. It could affect whoever. And because there is such a diversity of infectious agents out there, it's an enormous diversity. 1,500 at least identified human pathogens, of which, incidentally, to squeeze in one of David's points, one of which we've eradicated. So that's a very, very distant prospect. But there's an enormous diversity of pathogens out there. So when something new arises, it's always possible to point at Ebola or SARS-1 or mad cow disease and say, well, it could be like that. And that, of course, means the threat actually could be very serious. So, precautionary principle, you should treat it as if it was like that. That's what that would say. But the consequence, of course, is that it is entirely possible you may be overreacting, which is, to bring on another subject, one of the reasons in my evidence I put great store by, in the early stages, and I think David was alluding to this too, situational awareness is vital. Good intelligence, good information, good science, good scientific research done quickly and in a timely fashion to not only inform us about how we can control an outbreak, but also what we don't need to do as well. And I think that's turned out in the context of COVID-19 to be just as important, to understand what you don't need to do, because that also can be very harmful as well as what you do. And that brings me quite neatly, actually, just to flesh out a little bit more on some of the things David was talking about. In the UK's National Risk Register, we do distinguish different kinds of infectious disease outbreak that you're going to have to respond to, that you might apply the precautionary principle to. This is the current version, so published last year, I think. So one of them are called high-consequence disease outbreaks. And that's something like a localized outbreak, perhaps of MERS coronavirus or Ebola virus or something in the UK, which would be very serious, but the expectation is it could, with the right public health interventions, be contained. That's the expectation of those. And that, in fact, is actually, on an operational level, of how the UK treated COVID-19 for the first few weeks and months. So that's one possibility. But the other possibility, which they always recognise, but obviously has now more prominence now, is the fact that something could develop into a full-blown pandemic. And they give odds on the time frames in which that could happen. So that's one of the things you need to know very, very quickly. Are you dealing with, yes, something that is extremely serious and potentially deadly and again, David's absolutely right, particular threat to health workers and patients in hospital, would be something like MERS or Ebola? Or are you dealing with something that could spread out into the community? And there probably would be a precautionary principle applied there. Well, if we think it could go into the community, we should put in measures in place to prevent it doing so. But the way not to overreact is to have good situational awareness early.
When you're saying that you're looking at something that could go into the community, does that mean that you would expect there to be some minimum amount of evidence of that likelihood before you would take those steps?
Yes. So the difficulty is that the discrete piece of evidence you might get early is not enough. And the discrete bit of evidence, again, David alluded to this, is whether or not the pathogen can actually transmit from person to person. And I said there were 1,500 pathogens, but actually the majority of those don't. Just as David said, the humans are a dead end. Now, usually in the early stages of an outbreak, not always, but usually we get evidence of human-to-human transmission fairly quickly. So we can know whether one person can affect another. But what we don't know, and I'm sorry to bring in, this is Sinetra's area now, immediately theoretical epidemiology into this, but now we're into the R number, which I'm sure everyone remembers from the COVID-19 outbreak. So just because a pathogen can transmit from human to human does not mean it can transmit well enough. That means that a single index case can infect enough secondary cases that it will spread. Now, that piece of information is typically much harder to get at. So there is going to be a very difficult period of uncertainty where you've identified a new agent, you've established the bad news that it actually can transmit from person to person, but you still don't know whether that R number will be the critical threshold of above 1 or below 1. If it's above 1, it can spread in the community, in the wider population, and cause an epidemic or a pandemic. So that's the hardest bit for me to establish in the early stages, what the R number is.
And in that context, again, we're talking about the precautionary principle. I mean, it may not, but does the precautionary principle, or would a principle of precaution assist at all in terms of that response?
Well, it would say that once you've got human-to-human transmission, you, without any other information, you do have the possibility that this is actually going to develop into a major epidemic, a major event. We don't know that, but it is possible. And so there will naturally be a great deal of effort into containing the spread of the infection. Now, in a closed setting, like a hospital environment, for example, that's conceivable, that's manageable. You do much the same thing as you would for either, but it's what you do in the community, the possibility that gets out of those localized settings, and that's where the decision-making becomes much harder. How should you react?
Professor Gupta, could I bring you in at this point? Do you have any
Indeed, I do have
views?
some views which I have previously written about, specifically with regard to the precautionary principle, which I believe was actually misapplied during this episode. So if we think of the precautionary principle as something that we apply when we have uncertainty, I think the first thing one might do is to think of the areas, break down the areas of uncertainty. And to me, you can broadly break them down into 3 different categories. One, the first category is what we've been talking a little bit, what are the characteristics of this virus? Is it going to spread from person to person? How quickly will it spread? Does it create immunity? Where would it go eventually if we didn't do anything? And I actually think that we did have quite a good idea at the outset of what a coronavirus, a beta coronavirus of this, like SARS-CoV-2, what its biological properties were likely to be, what type of immunity it would likely engender. And we knew this because we coexist, we have co-circulating in the community a set of other coronaviruses which, one would say that the parsimonious judgment one would make at this point is that this is quite likely to behave like OC43, which is another beta coronavirus. And indeed, it has proved to be very similar in that people, so the characteristics of all coronaviruses, the human coronavirus we know about, is that you, instead of getting infected and becoming immune in the way that we do with measles or indeed smallpox, is that you get repeatedly infected. You become infected, you do actually become immune for a short period of time, even to reinfection, but then that disappears and you become infected again, and again and again and again. So these are models that, I mean, this system is different to the measles type system in that you become infected, recover, but become susceptible again. One misconception that was abroad, and then unfortunately many epidemiologists seem to subscribe to it, is that unless you have permanent immunity to a pathogen, that you do not reach a situation that we call endemic equilibrium, which is where enough of the population has immunity at that point in time for it to just sort of hover around an equilibrium. And this is simply not true. We, in fact, enjoy, if that's the right word, a state of endemic equilibrium with all other coronaviruses, with many other respiratory pathogens and other types of pathogens which have the same characteristic in which you don't get, an individual does not become permanently immune, but they do reacquire infection and go back into the immune category. So the establishment of herd immunity, or the herd immunity threshold, that process applies exactly in the same way to a disease for which you lose immunity as it does to one where you don't. And this is something that people have repeatedly got wrong. So I think we knew that SARS-CoV-2 was likely to head to that position. We knew that people would get reinfected. We also knew something, or we could have inferred something that's crucial to this whole problem, which is that your first infection carries with it a much higher risk of serious disease amongst those who are vulnerable. So that's a very important part of the puzzle. So these are three things, these are elements of the actual biological reality of SARS-CoV-2, which I think would be the most parsimonious assumptions that you would make. There's always the possibility that this is going to be a completely different type of coronavirus. So that's there. But in the schedule of uncertainties, I would say there was a reasonable level of certainty, or the probability that it would behave as it has behaved was always quite high. The second consideration had to do with, in terms of stopping, what can we do about it? So let's say that's where we're headed. It will come in, some people will die because it's their first infection, they're vulnerable, and then eventually it will settle to an endemic state. Well, that's all very well, but we don't, it's not ideal, that's not what we want. We want to stop the people dying who would die because of first exposure to this novel pathogen. So then the question is, what can you do about it? And could non-pharmaceutical interventions achieve? What was the certainty and uncertainty on that? And with that, if I could take the opportunity to just talk about what, in terms of lockdowns, let's just call them lockdowns, I think some things that Professor Heyman said are very relevant in that, to me, there are different types of lockdowns. There's sort of what I call the noble lockdown, which, we've observed from the time of plague, where a small village will stop people leaving when they're infected. And that's noble in the sense that, that is to contain the disease and stop it from spreading out. You could have a lockdown which I think perhaps New Zealand achieved, which is a less noble lockdown perhaps, but sensible enough, where you, if you're in a position to stop the disease from entering, you put the measures in place to stop it from coming in. And I think under a broader international collaborative plan, we may well have said that remote locations that can affect that kind of lockdown should be supported to put those in place. And then there's the third lockdown, which is really what we're talking about when it comes to precautionary principle being applied, which is that of, can we use lockdowns to suppress, to stop the spread of infection? And to my mind, that is one that over which a huge question hangs at, if I may, sorry, maybe this is not, at a very simple, I won't call it simplistic, simple level, you would imagine that any measures that reduced transmission from person to person would stop the spread within the community. But this is by no means true. Actions that you can take to protect yourself and to stop yourself from being infected, which we know work. If you stay at home and you are given the means to stay at home and have your food delivered, you will reduce your individual risk. But whether that sort of a measure can actually stop the spread or even slow the spread, I think there was a big question hanging over that, and we can talk about whether that question has now been answered. But at the time of thinking about whether to implement something like that, there was a very big question hanging over that. Then the third issue is, if we bring in these measures, what other harms will we cause? And to my mind, there was far less of a question hanging over that. It was clear that if you stopped a 90-year-old woman from selling toys on the pavement in Delhi, from selling those toys to make the few rupees that she makes to go and buy some very substandard food that just gets her through to the next day, that she will die. This was obvious. So given that sort of schedule of certainty and uncertainty, I would have thought that the way that lockdowns were rolled out were actually a perversion of the precautionary principle.
Thank you. We'll come on to the definitions of lockdown, if I can just stick with the precautionary principle just for a moment. I'm going to come to you, Professor Bambra, in a moment, but if I could just ask Professor Heyman if you had anything to add, just in terms of your understanding of the precautionary principle.
Precautionary principles, in my view, are extremely important, but it's a very difficult political decision, because precautionary measures will require modification, likely, at some point after they've been put into place. A good example, Mark alluded to it, was mad cow disease, where there was a precautionary measure on butchering to make sure that the meats were not being infected by central nervous system tissues. That was a precautionary measure which then became, after evidence was accrued, a policy within the government. Mask wearing was very important early on in the pandemic in Asia. Asians, as many of you know, or most of you will know, have already a habit of wearing a mask when they're sick with a cold or some other respiratory infection. And in Asia, very early on, governments instituted mask wearing as a precautionary measure. It was very difficult to do that in many other countries, and including WHO would not make those recommendations because they did not have the evidence that was necessary. But if you look deeply, there were other reasons that those precautionary measures were not provided. One of those was the fear that the masks, which were medical masks, would be in shortage in health facilities if indeed everyone were wearing them. But there were alternative methods. There were cloth masks that could be made very simply at home. Just to say that precautionary measures are important, and they can be used and they can begin to slow down an epidemic. They can't stop it possibly, but certainly slow it down. But they're very difficult for policymakers to use, because then if they change them, they may be accused of having falsely locked down or caused the population to suffer when they didn't need to. So precautionary measures at the beginning must be followed always by collection of evidence and modification on a regular basis.
Thank you. Professor Bambra, I wonder if I could ask you, much of your work concentrates on questions of inequalities. I wondered if there was any bearing of that in terms of the precautionary principle.
I think for this it's difficult because there's very strong evidence that people from more deprived communities, ethnic minority women, for example, had more adverse experiences during lockdown, which we might come on to. But also you've got particular vulnerabilities and higher rates of COVID-19 mortality and morbidity also amongst, say, more deprived communities. So there's a tension there, kind of like whatever you do. On the other hand, I think we didn't go into this situation with no knowledge at all. I think there's very much this idea that, you know, the virus would be an equaliser, it affects everyone. But our evidence from previous epidemics and pandemics shows that that's not the case. There's evidence of inequalities in Spanish flu, for example, 100 years ago, both between different ethnicities, for example, in North America, and then very much so in terms of different occupational classes, for example, in different parts of Europe, Chicago and so on. Similarly, we can see that with evidence in terms of the swine flu epidemic, much smaller, but nonetheless you get geographical inequalities related to population deprivation. So we knew that there would be inequalities, or potentially knew that there would be, going into COVID-19. So my views on that would be that there should have been more precautions. I guess I'm not doing it theoretically, I'm doing it in a real world sense. Not necessarily talking about the full lockdown, but in that early March period where particular events, large crowd gatherings, were allowed to happen, including, you know, fairly notoriously, and I mention it in my written statement, about the Liverpool versus, I think it was AC or Atletico Madrid or someone, a Spanish team, at a point where Europe was already having quite high levels of cases brought into Liverpool, when Liverpool then ends up with quite high community risk. So the precautionary principle there would have been not to let that event go ahead. And I don't think that's a zero-sum situation. Personally, I am a football fan. Would have been disappointing if it had been behind closed doors. But it's not on the same level as, you know, what later happens. So I think there are inequalities and ethical aspects around the precautionary principle. But it's about then thinking about better safe than sorry, to use Mark's words, but for whom that might be the case, because not all communities are considered equally. So that needs to be factored into some of these decision-making processes in the field. The second thing that came to my mind when colleagues were speaking was also about we're not making these decisions just by monitoring the disease and seeing how it evolves and its nature and so on. We're also doing it within a particular context, and for us that was a healthcare system that was potentially, or was under pressure already, and where there were concerns about whether it would be able to cope with a surge of cases or not, particularly surges in specific geographical locations. So a lot of work was happening, you know, locally within NHS areas of modelling bed usage and where you might be expecting to have problems. So I think the decisions aren't taken in a theoretical vacuum. They are within and what we could cope with at that point in time, or a future point in time, might be different from what, as it turns out, Germany could cope with, because they had more spare hospital bed capacity going into the pandemic.
Thank you. Yes.
Very quick comment. I very much agree with what Claire was saying there, but on the idea of protecting the hospitals, I think we'll maybe come to that later. That was a classic example of overkill in terms of precautionary principle as it happened.
Thank you.
But I'm sure we'll come on to that.
Professor Heyman?
Just to add what Claire and Mark have both said, the precautionary measures are based on what's known about other similar diseases, and that's why it's precautionary. It's because these diseases have been shown to be affected by this intervention many times, and therefore a precautionary measure is identified. I'll go back to mad cow disease. Mad cow disease was caused by a prion, which was a disease which was already known, a prion-related disease, and much was known about that. And so the precautionary measures for that disease, which was known, which is called Kuru, were employed in order to make sure that early on there were the proper precautionary measures for mad cow.
Professor Gupta?
If I could just make a small comment on both of these examples, which I think are very interesting, which is to take into account in the thinking, what are the costs of these measures? I mean, what were the costs of cancelling a football match in terms of the socioeconomic impacts? Not much, really, I would have thought. I know you didn't enjoy having the match cancelled, but in terms of making decisions, should we have a football match or can we stop prions getting into the food chain? One of the reasons they would have been good ideas is because they didn't, as far as I'm aware, have immediate socioeconomic costs that could not be mitigated. Obviously, the butchers or the livelihoods of people would need to be protected, and they could be protected. Stopping people from watching football can be awful, but it's not. I feel that is a very important part of this equation, this thinking, is that this is what we should do, even to be safe rather than sorry. But what are the costs of being safe?
Thank you. Yes?
Are you saying that the costs of cancelling a football match should be taken into consideration? Because we'd have to then trade off what were the risks of having that match go ahead? I'm just saying, let's say we don't know what the risks are of the match going ahead, but it could be this sudden explosion of cases which then overwhelm the health, Yeah, exactly.
But the way to make that decision, I think, is to think, well, if we cancel that football match, are people going to die of starvation anyway?
Well, I think the point is that they wouldn't.
Well, that's what I'm saying, but that's...
So we're agreeing? I'm not clear.
We are... I don't think it's a matter of agreement. I think it's a matter of what's the framework. Within that framework of what you can do and can't do, and even if it is massive overkill to cancel a football match, and you can also argue, all sorts in other directions of maybe it's better to allow this virus to, do whatever it's going to do amongst young people, or, there are lots of scenarios that you can bring in to say, should we not have allowed. In terms of the actual epidemiological outcome. But what I'm saying is that when we apply the precautionary principle, the reason why, even though we don't know, or even if we did know or didn't know, the uncertainty surrounding the impact of allowing a football match to go ahead, why you would nonetheless maybe be safe rather than sorry, that the main reason for that is because there isn't as far as I'm aware, huge tangible cost to cancelling that football match. So I'm just saying, if you think of that as the overarching principle, and then you say, well, what is the cost of telling people they can no longer trade who, survive from hand,
Yes, so it's how far can we apply the precautionary principle in effect?
No, I'm saying the whole way that you apply the precautionary principle has to have as a component of it the costs, the other costs of the application, not just the potential benefits, but also the costs of that measure.
Do you mean there, Professor Gupta, the ability to compensate for effectively the loss?
I think Professor Woolhouse got it correct, didn't he? Because Professor Woolhouse suggested that it is best, or it is preferable, if the decision maker, probably a politician or someone in that line, has as much knowledge as is possible. And therefore, and I think this is where Professor Gupta comes in, if the decision maker has sufficient or as much information as is available, the decision that person makes in relation to whether to permit something or prevent it is based on the best possible knowledge. And to take Professor Bambra's point, perhaps a football match in itself and the economic consequences of it are not very great in actual fact. But if there is a risk, an identifiable risk of significant harm, i.e. these people, I don't know how many went, 40 or 50,000 people, and they spread it to other people, could be very significant. I think that's what Professor Bambra was trying to say.
I think what I was trying to say is simply that in these two instances, what enabled them to be implemented, or or would enable them to be implemented, is that the attendant costs
That's part of the
are
knowledge.
manageable.
Well, yes, I see that. Yeah.
That I just think that that's something that often doesn't get discussed.
Yes.
The focus is on what would this do to stop the transmission, etc. But
I understand that.
you can compensate people for changing, altering, putting in practice whatever would all stop prions from entering the food chain. You're not. I wouldn't be too worried about will people starve to death if we cancel a football match.
I think I understand. And I think in actual fact we're going to discuss that on Wednesday and Thursday with the economists and the ethicists and so forth. I think that's big time. I'm sorry to just break it up. This is thoroughly enjoyable, but we need to let the snographers have 15 minutes every hour and a half. So we'll take a 15-minute break and come back at 1/4 the hour.
All right.
Thank you all very much. Right, Mr. Turner, when you're ready.
Thank you, Lord. We're here to discuss lockdown, and the inquiry expressly did not provide you with a definition of lockdown in your letter of instruction, merely stating that lockdown, the term lockdown, is sometimes used to cover all non-pharmaceutical interventions, including social distancing, travel restrictions, self-isolation and vaccine passports. The inquiry will not be adopting any specific definition for the purposes of these hearings. That's the inquiry's perspective, but I'm interested to hear, and whilst we're not adopting a definition, I'm interested to hear whether you would. Professor Woolhouse, from an epidemiological perspective, is lockdown a defined and well understood concept?
No, but I can give you a lexicological perspective. So the best definition that I've come across was published by Collins Dictionary in 2020, and they made it their word of the year for that year. And their definition was the imposition of stringent restrictions on travel, social interaction and access to public spaces. And I'm quite happy with that. The reason why I'm going for a dictionary is because prior to 2020, you would not have found the word lockdown in any public health or epidemiology textbook. It wasn't there. The concept was not formally recognised by any of the global experts in the field. This was completely new. It was hoisted on us by a combination of WHO and the Chinese government in early 2020. It wasn't there. It wasn't in the manuals. So there was no definition to work with. So I go with Collins Dictionary.
Thank you. Professor Bamborough.
Yeah, I would interpret it more narrowly as the stay-at-home order, rather than restrictions on other events, partly linking into what Professor Gupta and I were just discussing prior to the break about kind of cost and benefits. So for me, it's very much was that stay-at-home order would be how I would interpret lockdown and how I think it is interpreted in studies that have looked at the effects of lockdown tend to mean that period where people had very restrictive movement outside of the home. So that, and then in terms of just reflecting on the comments there about not having lockdown kind of in the public health dictionary, I would completely agree. But obviously there are interlinked concepts like quarantine in terms of, in effect, the noble lockdown of specific places or communities in the past.
Thank you.
I'm just going to defend against quarantine. I think that I personally see that as a separate concept. I'd agree they're part of the same family of measures. Yeah. They're all social distancing, non-pharmaceutical interventions, but I personally would draw a distinction.
Yeah, I would agree there's a distinction, but I'm just saying it's not as therefore such a kind of, it's an evolution of quarantine. It's not such a suddenly something comes in, and then obviously the kind of etiology of it coming from China and WHO might be something to discuss later as well, because I'm not sure I would agree with that.
We'll come on to that later. Before we leave the definition, Professor Gupta, do you have anything to add to your thoughts on the definition?
Just simply, I mean, I've already said one could distinguish amongst lockdowns on the basis of intention, with the noble lockdown, that want to keep it in, want to keep it out, want to stop the spread. With regard to the third possibility of stopping the spread, I do think that it's important to deconstruct lockdown, or the action of lockdown, different axes, which is one is sort of intent and the other is what it actually achieves. And I think the reason I say that it's not semantic, but because people tend to assume that when you lock down, that there will be some sort of proportionate effect on, for example, transmission. So, you know, what's correct, has to be true, is that if you don't lock down, the virus will, or whatever pathogen will spread as it would under natural circumstances. And it also is, it has to be true that if you lock everyone down, or if everyone is not allowed to spread, that it should notionally disappear. And what's not been taken, what people fail to think about is what happens in between these two extremes. Can you, let's say you lock 85% of the country down in the sense of tell 85% to stay at home. Does that actually mean that you slow transmission by 85%? Is it linear? How do you go from one to the other? Or is it actually rather more non-linear, in that unless you lock everyone down, you actually don't really achieve much? And these, I think, are questions around, really it's about the effects of lockdown rather than the definition of lockdown, but I think they've been conflated in ways that haven't necessarily been helpful.
Thank you. Professor Heyman, I'm going to ask you the same question, just whether you have anything to add on the definition, but if I could also ask you to have in your mind, Professor Woolhouse mentioned the fact that this wasn't a term that was used before 2020. Perhaps you could tell us about the kinds of measures. I'm conscious, for example, of your experience with smallpox in India, the kinds of measures that might have been used in place of a lockdown.
Yeah, what Mark said, I think, is right, that the term lockdown surprised everyone when it occurred. Before that, however, there were terms that were used to keep infections in a place. Cordon sanitaire, a French word, which we all know. A cordon sanitaire was an area locked down so that people couldn't leave and take the infection out. But that was local, or it was at borders. It wasn't really anything that was a generalized lockdown. However, during certain activities, and I'll cite smallpox eradication, there were infringements on movement of people when there was an outbreak of smallpox, including people who were infected and showed the infection, and people who had been contacts who were isolated in their households. This was done many times against the will of those people in parts of the world, and it was done without sanction of the government, but without interruption by the government. So many times police might have been involved, or the military, in making sure that people who were locked down in their residence, again, in order to prevent infection from spreading outwards. At the same time, it may have been required, if there were interventions, that people be vaccinated to contain the infection within individual people, prevent them from getting infected and spreading it to others. But there were never general lockdowns such as we saw in COVID-19, and I think many, many epidemiologists were surprised when Europe began to follow the example of China in complete lockdowns. But there were reasons that we can talk about later on as to why countries did that. One of those was the strain on their health systems in order, as a precautionary measure, to try to decrease transmission and prevent those centers from collapsing, really.
You're saying that measures that were being taken in the past, for example, keeping people in their homes, may have been taken without, albeit with the acceptance perhaps, but without the direct involvement of government. Who was making those decisions?
Those decisions appeared to be made locally by the local governments which were under pressure to stop the transmission of smallpox. Maybe Sunetra has some other observations on that, I don't know.
Professor Gupta?
You mean about isolation and
the
ring
forced
vaccination?
Isolation of people
No,
in
you're
India.
you were there doing it. I certainly don't have much to add there, except that, indeed, those are specific circumstances where you're at a particular threshold of eradication, and we're clearly absolutely, I mean, this is one thing I tell my students, it didn't just disappear because we managed to get the R0 below 1, that you needed those very specific activities to fully eradicate it. And that is a very different and specific circumstance where, again, if you think about the harms, they are to a small number of people who could easily have been compensated. I don't know to what extent the governments did do so, but they're very important. I mean, the fact is, and this is the bottom line, is one can use these methods to reduce individual risk. And I think a lot of the confusion arises from extrapolating from that to thinking of how it spreads in a population. And not only that, confusing the value judgments of, should you do this to people? That is very much dependent on the context, and this particular context was one where we were close to eradicating a disease that was a terrible scourge, and for which many people are very grateful. I mean, I remember being told suddenly in 1980, no, you don't have to go to Triangular Park anymore to get your smallpox little inoculation, and in terms of cost benefit, I think it'd be very hard to argue that that wasn't the right thing to do.
In that context, then, Professor Gupta, do you think that's the exception rather than the rule in terms of those particular circumstances justified those more stringent actions?
I don't think that one can generalise to what's the exception, what's the rule. I just think that it's very important not to conflate two very different circumstances, particularly, and make what seems to me often was more of a value judgment than a step back and think of what is necessary at this point in time.
Professor Woolhouse, you've noted the emergence of the term lockdown. Do I understand from what you're saying then that there wasn't a historical precedent for the kind of entire population lockdown that took place?
That's correct.
And what is, and this may be a slightly self-justifying question, but is there a justification for quarantining, or what was the justification given for taking that approach in terms of a whole population lockdown?
So there was a justification for quarantine, which I've already argued is a different concept. I mean, that's been around for centuries, if not millennia, the idea that somebody who is infected or is believed to be infected should in some way isolate and stop any potential spread from that person. That's very common, that's very accepted. I don't think that was controversial in the case of SARS-CoV-2 as it was with SARS-CoV-1 or Ebola or any of the other diseases we've been discussing, certainly not smallpox. I mean, there's lots you could argue about how quarantine is implemented, and particularly about who is subject to it, but the concept, I think, is well established. Lockdown is completely different. So some people have described that as lockdown as quarantine for everybody. So suddenly we're all suspected of harbouring the infection and all thought to be at risk of passing it on. And even at the height of the waves that COVID-19 that we saw in 2020, 2021, the number of people in the population that were exposed were typically not much more than 1% who were active, and probably less than that who were actually infectious at any given moment. So to quarantine everybody for something less than a 1 in 100 chance that we might, as a random person, be infected, that does seem rather disproportionate to me, and particularly if there are alternative ways to control the spread. I'm going to broaden out something I think Sinetra was getting at, but one of the things that frustrated me about lockdown and its implementation during COVID, what may happen in the future, was this was so often presented, particularly to both the Scottish and UK governments, but more widely too, as it's lockdown or nothing. That's your choice. You can lock down or not. And it was never, ever that choice. There were always public health measures that could have been chosen, could have been implemented to at least try to achieve the same public health benefit as lockdown with, to go to Sinetra's way of thinking, for a far reduced cost. But that was not how it was presented. It was presented as lockdown. And I think that comes back partly to your precautionary principle idea, that, OK, that's the safest thing to do. Let's just assume everybody's infectious. But it also comes from a very pervasive misconception that happened to us, that the risks of being infected and passing it on and suffering consequences of that were essentially flat, that everybody in the population was equivalent. And this was vocalised very clearly. Oh, am I allowed to mention individuals?
Well, no is the answer, but there are exceptions. So if you're going to talk about a public person, in other words, someone who is holding a public office and making views on those things, then we permit it.
Would Michael Gove count?
Michael Gove would probably count. He was or had been a cabinet minister.
Right.
Yeah.
So he was very fond of saying, we are all at risk. The virus does not discriminate. This was utterly false. This was false by, to use the mathematical, several orders of magnitude. In terms of risk of dying of COVID, a 75-year-old with comorbidities was at something like 10,000 times the risk of your average 15-year-old. I mean, this is absolutely, totally false, but it justifies lockdown because we're all at risk. Oh, no, we're not. We're absolutely not. That is just wrong. So,
Can I interrupt there?
Yes.
Is it not correct to say we're all at risk, but at a different level or a different degree?
My Lord, you'll be conscious of the thing there is no such thing as zero risk in life or public health. There has to be some sort of baseline. So, for example, we did a formal estimate, which we communicated to the Scottish Cabinet by Zoom in 2020 of the risk to school children if we reopened schools. And we had to make some estimate of this risk. So I had my team doing the research to try and find some way of expressing what the risks of these children would be if we did that. And we reported with the entire Cabinet on the Zoom screen, so I could see their expressions as we did this, that we found it very hard to estimate the risk to a child of getting, let's say, a fatal COVID infection if they went back to school because it was so low. The best we could come up with it was roughly equivalent to the odds of that child being struck by lightning in the playground. Okay. And that, fortunately, the Cabinet agreed was an acceptable level of risk. It was way lower than their chance of having a fatal road accident on the way to and from school. So there has to be some baseline risk of which you say, no, we can live with that. And being struck by lightning is something we tend to live with.
Sorry, I interrupted you, but thank you.
Just to be clear, when we're talking about risk, then you're not talking about risk of infection, you're talking about risk of consequence of fatalities or serious morbidity.
Yes, but all the risks are heterogeneous. None of them are flat. When senior politicians are saying the virus does not discriminate, the virus is ageist, it was sexist, it was racist, it was against low education, it was highly discriminatory virus. So that's just an incorrect statement. And the reason I'm raising it here and now is because that statement, that sort of statement, encourages blanket restrictions. It encourages lockdown. And the moment you recognise that actually the risks are highly concentrated in a very identifiable subset of the population, your thought should be not locking down everybody, it would be, how do you protect those people? Yeah. Here is a group that we can identify and we know they're extraordinarily elevated risk of serious consequence of infection. How do we protect them? A lockdown is actually, we'll come to this later, not the best way of protecting them.
If I could perhaps paraphrase you, Professor Wheelhouse, you've described this, I think, as almost implying a non-zero probability of those risks would effectively justifying lockdown. Is that an appropriate threshold, do you feel? Do you feel that the threshold that was marked for lockdown was sufficient?
No, I think this was the precautionary principle gone mad. The fact that we're actually locking down, quarantine. Well, I say it's quarantining everybody, really. Although Sinetra raises a very good point. In practice, of course, that's not what happened, is that millions of people were not fully subjected to lockdown because this country had to function. And they were able to make their contribution in that context of spreading. One more thing before I let Sinetra in. And the reason why it still worked and why, as the mathematics would say, when you did that, well, you won't stop the spread. But the spread did slow significantly during periods of lockdown, is because the people who were functioning, this includes everyone up to healthcare workers, were subjected to a huge array of what I call blanket COVID safety measures. Traditional ways of stopping something spread. That goes to masks, it goes to hygiene, it goes to ventilation, it goes to all the precautions that we got used to taking. And the evidence is actually that worked to a significant extent. So without them, these millions of people actually being locked down. But the rest of us were not allowed the benefit of that, unless, interestingly, we happened to be professional footballers who were allowed to function during the thing. And they did all these COVID safety measures, and including a lot of testing, and they were able to play football. Well, I would have liked to play football. Well, actually, my football playing days are probably a bit behind me. But I would have liked that privilege during lockdown, and I would have taken the same precautions as the Heart of Midlothian football team did. But I wasn't allowed to. So we did know how to manage to control the spread without resorting to quarantining everybody, but we chose not to implement it. We chose to go the lockdown route.
Thank you. Professor Gupta.
I'd just like to go even further and say that with regard to risk, we actually exposed those who were at high risk during periods of apparent complete lockdown, people who were actually vulnerable to severe outcomes were allowed to go and clean the hospitals and drive our buses. And many of us who weren't at high risk stayed safe in our very comfortable houses and gardens. So, and I think a lot of the correlations with ethnicity and socioeconomic status cannot be deconvoluted from that, because, I was just reading this morning that the rates of obesity, how they link to socioeconomic status, and it really is so stark. I think there was considerable turning a blind eye to the fact that some of the people who were out there performing these essential services were actually the very people who should have been furloughed, given the means to isolate themselves.
Thank you. Yes.
Yeah, sorry. I was just wondering, because I completely agree with some of what we're saying about who had to go out to work, key workers and so on, largely drawn from low income and ethnic minority groups and women and so on. But we're sort of acting, and I don't know if we're expected to act, as though, when we talk about we made the decision, the decision ultimately was a political decision. It wasn't made by epidemiologists or the public health community. So I think I just want our audience to know that who we mean when we say we made this decision, and that obviously political considerations were always going to come into whatever the science was. And it may be that a political precautionary principle was actually politically, it's perhaps easier to lock everyone down than to say we're going to lock you, you and you, but not you. That would be my interpretation.
Thank you. We will come on to discuss the manner in which the decisions were taken and by whom in due course, just to confirm that. Professor Woolhouse.
Well, I can wait till then. If you
No. If there's a point you want to raise,
well, it was just. Apologies, Claire. I don't agree with that. I think that the scientific advice frequently was driving politicians, particularly down south, to enter a lockdown they didn't want to enter, and the culmination of that was right at the end of 2021, 2022, the Omicron wave, when the scientific advisors were absolutely adamant that something very similar to a lockdown was needed again. They were predicting the worst wave ever in the history of the pandemic. This is very late on, we're now into early 2022. The UK government went against that advice. It didn't implement a lockdown, and there was no worst wave of the pandemic at all. So I think it's not the politicians purely response. I think the scientific advisory community also played a very significant role in the fact that we ended up in lockdown as frequently as we did.
Thank you. Professor Heyman?
Thanks. Yeah, I would just add to this conversation that it was a time of great confusion because many of the epidemiological modeling was suggesting that you could interrupt transmission or that you could stop transmission if you got to a certain level of infection of the population. And this added confusion to whether or not to lock down and to try to stop transmission or to let transmission occur and reach that threshold. So it was a very difficult time when some modelers were saying, let's get to 72 or 75% of all people infected and transmission will stop. And others were saying, let's lock down now to prevent transmission, which would have prevented the creation of this herd immunity, which would stop transmission. What was the problem, though, were that the modelers were not using, as Sunetra said, this database from the known coronaviruses, that they could not provide lasting infection prevention, and therefore there was transmission even in people who had been infected one time from them to others as they became infected a second time. So it was a very confusing time, and political leaders were having messages from many different sides, I think. I think Mark might agree with that these messages were all coming at the same time. Are
we talking the very
early on,
the lead up to the first lockdown?
Before the vaccine.
I completely agree. It was a very confusing time.
And if you ask New Zealand at that time, they would say we've locked down in order to wait for a vaccine that will protect us. Whereas if you asked European countries, many times they said we locked down to prevent our health systems from collapsing. And in Asia, they were locking down to slow the entry of the virus. And they were only locking down where transmission was occurring. So there were a whole series of things going on in the world that added great confusion to the decisions made by the political leaders with evidence from their own countries.
Leading on from that, we've spoken about the fact that there was no precedent for lockdown before the United Kingdom and Scotland lockdown. There were previous events on which lockdown may be said or may be thought to have been built. Professor Heyman, perhaps you could tell us a little about the reaction to the SARS and MERS diseases and our viruses and the position in China.
In the SARS outbreak in 2003, and that was an outbreak, that was not a pandemic. There were many outbreaks throughout the world which occurred as a result of the emergence of SARS coronavirus 1 from an animal population to humans in a live animal market in China, which is the understanding. That virus, at the time when it was first identified or first understood that it was spreading into other countries, there were some decisions that the Director General at WHO had to make, and that was, should we attempt to stop this virus from spreading, not knowing whether or not it will become endemic or whether it will cause a series of outbreaks, or should we just let it travel on its own course? And her decision at that time was to recommend that travel not be continued to countries where outbreaks were occurring, because it wasn't clearly understood what was going on with the epidemiology. As soon as that epidemiology was understood, however, those travel restrictions or recommendations were lifted by WHO, and the virus did not become endemic. But as I said earlier, that virus reproduced low in the respiratory system. So in order to get it out and transmit, there needed to be coughing or sneezing, which put the droplets into the air face-to-face to another person. Move up to MERS coronavirus, which emerged later after the SARS coronavirus 1, and that virus is known not to transmit easily from human to human, except in a setting where there's improper infection prevention and control in hospitals. South Korea is a good example where there was a major outbreak because they weren't, in fact, using the appropriate infection prevention and control measures. But we understand that this is a disease which has not become endemic in humans, but is endemic in camels. And camels continue to spread it periodically to humans, who transmit it in health facilities occasionally from person to person or to close family contacts. And then we had coronavirus SARS-2, which we're talking about at present, that caused the COVID pandemic, an entirely different epidemiology because it was transmitted by smaller droplets, not only face-to-face, but also through the air to other people at a distance.
And did those lessons then lead to the reaction in China, the approach that was taken in China to the initial outbreak?
The reaction to the initial outbreak in China was to make it illegal to sell wild animals in markets. And what that did was drove the trade underground, and there's evidence that it was still going on during that period. When the second outbreak occurred in China, it was quite, I think, an embarrassing moment for China, because in the SARS coronavirus 1 outbreak, they had been accused publicly by the Director General of not sharing information. This was 4 months into the epidemics, not sharing information, and they immediately rectified that situation and became quite collaborative. When they then were accused of trying to hide the virus in 2020 or 19, which is really not yet understood whether they were trying to do that or not, they became very sensitive to this, and their reaction was to try to stop the transmission, as they had done with SARS coronavirus 1, by similar methodologies of making sure that there were these isolation around communities where outbreaks were occurring, and eventually locking down those communities and regions of the country, and eventually the whole country.
Do you think the Chinese approach reflected or affected WHO advice that followed thereon for the rest of the world?
I can't answer that question. I know that there have been many questions as to why WHO was not being more aggressive towards China early on in the pandemic. I do know from understanding that China did share quite early in the pandemic, and the virus strain sequence was available, although it was then locked down by China, but it had become available globally. And WHO was collecting more and more evidence, meeting with many different groups to understand what was going on. And their understanding was that this was something which China was trying to stop by locking down markets where they thought transmission was occurring, and they accepted that as a reply from China.
Did the WHO endorse the approach of lockdown as a way of addressing COVID-19?
It's a very difficult question to answer. I chaired a group, and our emergency group did not encourage lockdown with WHO. But WHO works on advice from many different groups, and from some of the groups that they were working with, they evidently understood that lockdown was a measure that should be taken in many countries. I'm not sure whether this was because of the concern for health systems in those countries or for other reasons, but it was clear to our emergency advisory group during the pandemic, early in the pandemic, that this virus was destined to become endemic because of the facility with which it was transmitting from person to person and the widespread of outbreaks.
Thank you. The inquiry has already heard evidence regarding the UK and indeed Scotland's pandemic planning, and the fact that that was largely predicated on influenza outbreaks. Excuse me. Professor Heyman, do you feel that the planning and government exercises associated at that time prior to the pandemic were sufficient?
The exercises primary to the pandemic, at least when I was involved with Public Health England and before that Health Protection Agency, were aimed at influenza-like events that were occurring. And in fact, during the pandemic of 2009, there were attempts made in the UK to stop transmission by the use of isolating students in schools, because students are known to transmit influenza to their families from schools. And so there were attempts made in schools and in other communities to wall off outbreaks using oseltamivir and other drugs in order to try to stop transmission. And it was known that this had not been effective. So there were some understandings of influenza, but those understandings clearly did not apply, we now know, to COVID-19.
To your knowledge, was there any consideration of locking down within the UK or the Scottish Government's plans prior to 2020?
To my knowledge, there was no plan on lockdown.
Professor Bamborough, are you able to tell us, or any other matter you wish to discuss, but are you able to tell us what the planning was with the extent to inequalities issues?
Yes, for the COVID UK Inquiry Module 1, I was asked to review multiple planning documents from around 2009 onwards. And these are all detailed in that report in relation to how they talk about inequalities, which I'll come on to in a moment. But I just wanted to support what Professor Hayman had just said in regards to there also being in those documents, which are multiple, some of them are huge, absolutely no mention whatsoever of the sort of stay-at-home order style of lockdown that we experienced. And in fact, in the 2011 influenza pandemic strategy, it makes it quite clear. They note certain types of these types of restrictions, but there's it says that basically these won't happen, so we haven't decided to discuss it. I have the exact quote, but I've been told not to rustle my papers. But I can come to that in a moment. But with regards to the inequalities aspects, these are also something that are barely considered with any of the planning documents, so the sort of things that we've been alluding to in terms of particular socioeconomic status, ethnic minority groups, and also in terms of a kind of wider range of comorbidities that we would understand now. Largely they talk about age, very specific clinical risk factors, for example, people with asthma, pregnant women and so on, but it's a very narrow definition, and that's all that then factors into the planning documents. And even in the equality impact work around the pandemic planning. Just here.
I could give you two quotes from the...
That would be good. I do have one here, though. Yeah, here. So it talks about, this is the UK Influenza Pandemic Preparedness Strategy 2011, with which you're probably all quite familiar, and has the Scottish Government logo on it as well. And it talks about around travel restrictions, mass gatherings, etc. And it says the working presumption will be that government will not impose any such restrictions. I think so. It's not taken into consideration. So from that point of view, it does come across as a unplanned event, shall we say.
Please, may I just elaborate that quote with one more short bit of it. The UK government, well, the government means the UK government, the UK government will encourage those who are well to carry on with their normal daily lives for as long and as far as that is possible. That's the planning.
And it continues, the emphasis will instead be on encouraging all those who have symptoms to follow the advice to stay at home and avoid spreading their illness. And then there's stuff,
ones who are well,
yeah. And then there's stuff about
with their lives.
Potentially cancelling or postponing events, which come back to my football match from earlier.
Thank you. We've spoken about lockdown, the pandemics that we know about. Perhaps I can move matters just for a moment into the slightly hypothetical in terms of whether there might be in the future a justification for a lockdown or something approaching it. Professor Woolhouse, in your view, are there circumstances which might justify a lockdown approach in respect of a potential future pandemic?
So I think Sinetra has already alluded to those sorts of circumstances when you were talking about the eradication of smallpox. So where the goal is a public health benefit, a common good of that magnitude, and it is known where you can target this kind of intervention, then I think there's a case for it. I think obviously the people involved would have to agree to that too. But I think there are circumstances where that might be the situation. And you could argue, as I believe WHO did, but David was there on the ground, that when Chinese government had locked down the city of Wuhan in second half of January 2020 in an attempt to eliminate the virus from Wuhan, you could argue there was some justification for that, if that would actually have worked. But it was very unlikely to work at that stage of the pandemic. It had been far too established. But the principle of trying to stop something at source, yes, I think then you might have a justification. But David said something very, very important when he was speaking just now. He said, I think we were talking by January or certainly February, COVID-19 was destined to become endemic. So once that realization has landed, and I have to say, personally with me, it landed in mid-January 2020, but before China even tried to lock down did lock down in Wuhan, once that realization has landed that it is destined to become endemic, that you have no possibility of eliminating it within your borders or eradicating it globally, then I think the justification for lockdown evaporates. Because you're now going to be living with the virus, as the phrase was, whatever you do to make living with the virus tolerable from both a public health and a societal perspective has to be proportionate and sustainable. It has to be, because the virus is going to be there indefinitely. That's what endemic means. So it all comes back to situational awareness. Again, where are you on that spectrum in those crucial early weeks and early months? You've got to make some important decisions then. But what you don't do is take a tool, such as lockdown, which is designed as a way of eliminating or eradicating in the early stages, or indeed at the end game in the case of smallpox, and then apply to that tool to a situation where the virus is endemic and it's clearly not suited. It's completely the wrong tool for that situation. So yes, the short answer is yes, there are circumstances, but they had gone certainly by February 2020 in the case of COVID-19, in my view.
I'm going to come to Professor Heyman first, then I'll come to you, Professor Gupta.
Yeah, just to follow in what Mark said, with which I totally agree, the tools available for outbreak containment or outbreak investigation and stoppage were completely eliminated in Europe. Europe didn't apply those principles, whereas Asia had already begun to do this. Asia was investigating initial outbreaks, finding where transmission was occurring, shutting it down, moving on, because they investigated not only who was infected, but where they became infected. And they were able to do contact tracing, isolation, and basic public health measures that slowed the entry of the virus into their countries. They had no intention of eradicating it. They wanted to slow it coming into their countries. Whereas we didn't use those principles in Europe and North America, we used one principle, lockdown, which was very strange to the public health community, which knows how to deal with outbreaks and pandemics, and was not able to do that because those tools were preempted by lockdown.
Thank you. Professor Gupta?
Yes, I think Professor Woolhouse's description of, how do we, once we realize something is very likely to become endemic, how can we shepherd it to that state in the best possible way? I feel should have been the correct consideration at that point, meaning we'd want to avoid deaths of vulnerable people, meaning we'd want to avoid hospitals being overwhelmed, all of those criteria. But how do we do that? And I think actually one should not dismiss lockdowns entirely as a tool in shepherding populations to endemicity. I think the costs of it are typically too prohibitive. But an interesting interestingly, there have been a couple of papers that show that you could surgically apply lockdown in a completely different way, which is rather than lockdown to try and stop the spread, to prevent the entry, can be achieved at a local level perhaps. Lockdown to stop the spread at its initial, when it's just growing, is very difficult. It's a bit like trying to stop a torrent of water because, most people aren't immune. So the virus has this enormous sort of resource at its disposal and will spread. It has this enormous force of spread. But as it approaches this endemic equilibrium state, it starts to lose that force a little bit. But what can happen, and often causes problems, is that instead of going straight to that endemic equilibrium, typically in these systems, it's sometimes that it will overshoot. In other words, because it still has this momentum, more people will get infected than is necessary for endemic equilibrium to be established. And there have been a couple of publications recently showing that lockdowns implemented surgically for a very short period of time as we approach the endemic equilibrium could actually mitigate the sort of overshoot and then subsequent second larger epidemic and take us even more quickly towards this desired place where we, live, accommodate. We have an accommodation with the virus. So I'm saying all this because I really would like to underscore that, this is, and I'm sure all of us, this is not about being pro-lockdown or anti-lockdown. It's about thinking about how this very specific tool could be applied to solve very specific problems. And I think we've suffered enormously throughout this period in having that sort of factionalization, not just politically or for socio-economic, in consideration of socio-economic reasons, but just as a sort of emotive response to a measure. I mean, it's a measure. Does it work? These are the questions we should be asking. How can we make it work? Can we implement it for a short period of time? Can we implement it within a particular group? These are the questions I think we should have been asking and should continue to ask.
Professor Bambra, I'm talking about justifications for lockdown. In your written response to the inquiry, you mentioned what you've described as the fundamental human right of health, along with other human rights, such as the right, I think, for restricted children to be mentally and physically fulfilled. With that in mind, do you consider that these rights are compatible with or in opposition to with a lockdown approach?
Clearly is going to depend on who is vulnerable to whatever the virus bacteria is. But in the present case, especially given the work by Mark and others in terms of looking at the absolute risk of children, then the trade-off there would clearly be on the side of anti-lockdown in terms of... But I think, going back to what Sinetra said, I don't think any of us want to be painted particularly into a anti or pro. There is a middle ground, which I think we'll come on to talk about later, around more traditional public health measures of contact tracing, mask wearing and so on. But certainly, yes, you're looking at a trade-off between lots of different rights to health are in play within a pandemic, but also within a lockdown, in terms of, in order to reduce COVID-19 mortality, as it turns out, we're then undermining the mental health and well-being, for example. So that's another aspect of a right to health of everyone potentially, or certainly, and some people more than others. And then that's that trade-off between who you're protecting through lockdown and who gets harmed by lockdown. And there will be overlap between that as well. So the right to health is very much in tension, because it's in a sense it becomes who's right and what particular aspect of health, right? If the only measure is COVID-19 mortality and morbidity versus kind of everyday chronic illnesses that were happening, everyday emergency heart attacks and so on, and then also new kind of lockdown-induced morbidity in terms of particularly mental health, but also we can see it in terms of evidence around reduced physical activity. You get a spike in obesity rates during the pandemic as well.
Professor Woolhouse, you mentioned Disease X, and without wishing to go Hollywood, one can imagine circumstances where diseases are so severe that lockdown might be considered to be the only option. In your view, are there circumstances in which a lockdown might be justified?
There is certainly possibility of more severe infections than COVID-19, but that was quite bad enough, and the toll that it exerted on the people of Scotland and the UK and the world was huge, enormous, when an awful lot of people died. So I think it's very important to come back to, both David and Sinetra were saying this, I think this not being anti or pro-lockdown in that sense. And where the confusion arises, I've said it before, but I'm going to say it again, is this tendency to think, well, we have two options on the table. One is to lock down, and the other is to do nothing. And then, in these kind of public discussions, I've heard many times, but surely, Professor Woolhouse, that means more people will die. If it did, I would never, ever put that forward. Far too many people died here and around the world because of lockdown. It is not a choice between doing lockdown or doing nothing. It is a choice between doing lockdown and all the other measures, and we've raised many of them now, that would achieve the goal that Sinetra wanted to achieve, what she was saying a moment ago, of reducing the transmission rates and protecting people who are most vulnerable to this virus and keep the death toll down. So if and it's a very good question, if you were to ask me, but could you achieve that? Could you have less lockdown and fewer people dying? And my answer to that is emphatically yes, you could, if your public health response had been appropriately tailored to the situation we found ourselves in. And I do want to make this very clear, certainly for the members of the public and other people in the room. Being against lockdown does not mean ever that you are in favour of more people dying. That's not the trade-off.
Thank you. Professor Heyman, knowing what we know now, were there any benefits from having lockdown?
Lockdown is a series of different circumstances where lockdown can be locking down a football match, as was said earlier. It can be locking down a community to prevent them from moving outside the community to spread an infection. It can be at borders. It can be many different situations. Lockdown was used in many European countries, including in the UK, because of the threat to the health system. And when a lockdown is used as a precautionary measure such as that, which I think we all agree it was precautionary, then there's an obligation to regularly review the data coming from the country and from other countries to see when that lockdown can be modified. Because lockdown as itself is not a goal. The goal should be to lock down and release lockdown and having accomplished something. So if the hospital system had been protected early on, then, things could have changed in a different way, and lockdown theoretically could have been removed at that point in time, understanding what was going on in other countries, that, for example, primary schools were not an area where transmission was going from school children back to their homes, and other issues that were known throughout the world. So lockdowns in themselves can be used as a measure to short-term prevent something from occurring, but the obligation is that there's continuous review and an attempt to unlock as soon as possible.
You mentioned there the timing. Professor Gupta, could I ask you, how important is the timing and focus of intervention?
Well, again, as I've mentioned, I mean, that is the critical question. And there was this sort of understanding or sort of general impression, or this idea that if you lock down earlier and harder, that you might have been able to eliminate it. And some of these precepts, some of these sort of statements were taken as truths when they were merely speculations. And in fact, I would say that the weight of epidemiological thinking, conceptual thinking, would tell you otherwise, that it is actually extremely difficult to stop a virus of the nature of SARS-CoV-2 from spreading. As I said, I think you can, in any case, it's the notion that you can keep something from leaving a place, the noble lockdown, has some merit. The notion that you may close your borders completely and stop it from getting in, or at least slow it down, has some merit. But the idea that you can stop something from spreading when it has so much potential energy just by using imperfect, perforce, lockdowns is something to be questioned. But one of the things that was also taken for granted, or as a truth when it was not, is the idea that by the time the virus was discovered or known to be a threat, that it hadn't really spread in Europe or in some of the major urban centres anyway. It was just assumed it hadn't come in. Now, this was also slightly problematic because, if you think about the amount of air traffic that exists between Wuhan and London, it seemed highly improbable that it hadn't come in at all. And one of the disagreements that I had with Professor Ferguson was indeed the extent to which it had already spread, which I felt effectively what the model that was used to guide lockdowns assumed was that it had only just started to spread, that it had a very high infection fatality rate, and therefore going in at this point might actually slow it down. And theoretically that's sound, and they used methods to fit it to such data as were available at the time. So there's no, there are people who tend to criticize them on their methodological grounds, but I think what they were doing was completely kosher. It's just that actually you could fit a whole range of other possibilities to the same data. And one possibility would be that among those possibilities that the virus had already spread to an extent. I think fundamentally models are not very good predictive tools. They're fantastic conceptual tools. And any simple model that is constructed on the basis of what we knew, which is the biology of the other coronaviruses, would tell you that, we weren't in a position to make judgments about where we were at in the course of the pandemic, and indeed also if you take into account the fact that you lose immunity, and also that there, and we haven't talked about this, it's very important, seasonality plays an extremely important role in respiratory infections. You have a model that can fit the data under a very large variety of circumstances. So first of all, you have this huge uncertainty of where you are in the pandemic. Secondly, applying measures to control the spread can only work to delay it, if they work at all. And one thing to remember is if you impose a lockdown and it doesn't actually work, then you are effectively doing nothing anyway. So given that that is one eventuality, or one possibility anyway, you have to think that, okay, so we're assuming that it will stop everything, but then you have to ask the question, to what end? Okay, it delays it. That could be good, but, you can't delay for an indefinite period of time. So what are you putting in place then? You're buying some time? Well, maybe. Why not? But you can't buy time indefinitely given the costs of that measure. But overall, implementing lockdowns early on to stop the spread of a disease when nobody's immune, or there may be some cross-immunity with the other coronaviruses, but we'll come to that later, but is a big ask, and it's not clear what it would achieve. Whereas, as I was saying, there are a couple of papers now that suggest that maybe applying some form of short surgical lockdown at the point where it's becoming endemic could have some benefit. So the timing is crucial, but it's very difficult to implement these, to follow those theoretical predictions, because unless you know where you are at in the course of the pandemic.
Thank you. Professor Woolhouse.
Can I follow up on Sinetra's very last sentence there, because this comes back to the situational awareness issue that's come up a lot this morning. You need to know, just as Sinetra said, where you are in the epidemic, and that affects what measures are appropriate to implement at the time. Now, I know this inquiry heard from a colleague in New Zealand last week, and New Zealand gets a lot of praise for the way it managed its pandemic. And they get a particular lot of praise, slightly irritates me, for acting early. But they didn't. They did not act early. So New Zealand closed its borders round about March 20th. If the UK had closed its borders round about March 20th, just as Sinetra said, that would have had almost no impact. It would have had no impact, no detectable impact whatsoever, because in the UK, unlike New Zealand, the virus was already firmly established. We know from genomic evidence, that's evidence you get from looking at the genome sequences of the viruses, and that allows you to trace their origins. But during February, there were hundreds, bordering on 1,000, of separate introductions of SARS-CoV-2, the virus that causes COVID-19, into the UK. It had poured in, mostly from Europe. That was not the case in New Zealand. So New Zealand closing its borders, fine. The stage they were at would work. For us, it wouldn't. It would never have worked at that time. As it comes to lockdown, New Zealand, who acted early, actually locked down 3 days after we did in the UK. That's not early on a calendar date, but it's very early in terms of where the epidemic had progressed in that country, in that very isolated country where the very few cases had actually reached by that stage. So they acted early with the benefit of hindsight from the rest of us. But there was no, if the UK had wanted to replicate what New Zealand did, we would have had to lock down probably in late January, certainly first week or two in February. Sorry, I beg your pardon, shut our borders in those cases, and have locked down by mid-February. And those were absolutely not on anyone's radar at that stage of events. They became on people's radar into March when it was way, way too late. Closing the borders would make no difference, and as we'll come to, lockdown didn't actually make a definitive difference in the end either. So timing, exactly as Sinetra said, is absolutely context dependent. What worked in New Zealand when they did it later than us wouldn't have worked for us.
If I could pick up on a couple of things that you've mentioned there, or lead on from a couple of things you mentioned there. You mentioned that the inquiry heard obviously last week from the Swedish and New Zealand experts. One of the matters that they raised was the duration of the pandemic that was being anticipated at that time. In March 2020, are you able to give us any indication of what your view or understanding was on the likely duration of the pandemic?
In late January 2020, I got into an email argument with a fellow advisor, who turned out to be a fellow advisor in Scotland, because I was saying, in my estimation, based on the analysis we'd done at that stage, that this would be, and I quote, a 2-year event with multiple waves. And I was told that was utterly fatalistic, unrealistic, that was far too pessimistic, we shouldn't be planning on that basis. So I was saying that by late January. Papers were published, preprints were published in February, again, doing exactly what Sinetra was talking about how this virus would how that would do the transition to the endemic state. And they were published at preprints, but then in one of the leading scientific journals in the world, called Science. There was papers published in that. That paper came out in March, exploring the transition, including to seasonality, just as Sinetra said. So our community was aware that this was going to go endemic from, certainly, we started to be aware of it from late January, and by early March, this was absolutely clear to the majority of us. But that simply did not stick, not only with a lot of politicians, but also with a lot of other scientific advisors. Would not stick with them. But it was clearly the case.
Professor Heyman, in your written response to the inquiry, you provided a table with cumulative mortality rates for Asian and European countries. Can you clarify for us if there were any differences between these countries in terms of methodology to diagnose the cause of death, and whether we can use those figures as any kind of comparison?
I think we can use those figures as an indication of several different things. Number one is the early response in Asian countries where they slowed the entry of the virus, but also the fact that this virus was lethal to people who were obese, as we heard earlier, and also to the elderly and to people who were not being shielded properly, who were at risk. Early on, countries that began to shield those people or who had lower prevalence of those comorbidities may have been the countries which had lesser mortality at the start. And so in Asia, where the populations are sometimes very uniform in countries, there is a uniformity also in the response, and that response was that people were willing to wear masks early on and do other things that more heterogeneous populations weren't willing to do. That solidarity may not have been there. So I'm talking in circles, I fear, but what I'm trying to say is that in Asian countries, there's a difference in the comorbidities. There may be fewer comorbidities in certain populations than in others, especially European populations. And there had also been the SARS coronavirus 1 outbreaks, which led to strengthening of their contact tracing activities and also strengthening of their hospital facilities so that they had actual facilities where they could isolate people very easily in these countries that had SARS coronavirus 1. So there was better preparation. There was a different response in that they were locking down not entire economies, but where transmission was occurring and containing outbreaks, letting the virus enter more slowly until they could figure out how to protect the populations that were vulnerable. In Europe, as we've heard, the virus was already present early on in January 2020, probably endemic already at that point in time, and therefore the measures that were taken were different for different reasons, but mainly for hospital reasons, because the hospitals were no longer able to deal with the patients who were becoming ill.
Thank you. Professor Bambra, we're talking about early interventions in an infection situation. One of the things that you and others have mentioned to the inquiry is the necessity for impact assessments to be undertaken in respect of any responses. Do you think, in the context of an early response, undertaking those kind of impact assessments is practical?
Yes, because firstly, it should be, so we're talking about health impact assessments and health inequalities impacts assessments, which are standard practice. Certainly the health HIA is a standard part of a public health toolkit within the UK and within Scotland, and should be part of the planning. So we come back to the lack of planning, and obviously it has just been referred to that the Asian countries did better in their planning for this kind of situation. So we can do quite a lot of those impact assessments in advance. For example, I mentioned earlier how we could have predicted that there would be inequalities across certain social stratifications, but also that certain comorbidities were likely, people with those comorbidities were likely to be more impacted. But that's not there in our planning. So we can do quite a lot of that in advance, and then even in a real-time situation, because you're basing it on quite a lot of existing knowledge about how that we've just been discussing here with colleagues, you can at least have different options available that could then be taken. And again, it's about that might be something that you would then continually have to update. It wouldn't be a static document, but something that would change as the nature of your wider scientific understanding goes on. Even, we learnt about kind of new clinical risk factors, new social risk factors over 2020, for example. So you would constantly update that, but it's not something that I would consider to be like an onerous task for people with expertise.
Professor Woolhouse, in your experience, do you feel there was enough done with respect to impact assessments in the recent pandemic?
Before we went into lockdown, I'm not aware there was any impact assessment done whatsoever, which is absolutely extraordinary for government policy delivered on this scale that is clearly going to have enormous impacts on day-to-day lives of practically everybody and on the economy, on mental health and everything else. So I find that absolutely astonishing that no one had paid any attention to this. On the matter of timing, which is how you framed this question, once we're past this phase where we're thinking about elimination eradication, so we talked about the possibility of very severe restrictions to try and stop something starting, but once we're past that phase, and we've just established we were past that phase in February, there is a very simple and very effective maxim for dealing with an event like this, and that's that earlier intervention can be less drastic intervention. And I think a lack of understanding of that trade-off also informed the decisions to go into lockdown. And so, and this is part of the answer to the question, well, but then what would you do to stay out of lockdown? What would you do? And one of them is that even if you're just talking about non-pharmaceutical interventions, and including some kind of social restrictions, social distancing and so on, that if you intervene early, you don't have to intervene so hard. And the reason for that is we intervened hard because we had allowed the epidemic curve to rise in early March, and all the talk was about getting it down again. Well, that requires a considerable effort in terms of intervention to turn the thing around. If you don't let it rise up in the first place, you don't have to put that extra effort in. And the prerogative of trying to turn the epidemic curve around was one of the reasons why we had the more drastic ends of the lockdown intervention, of which I normally talk about three. So one is closing schools, one is having a stay indoors, and one is actually the stay-at-home orders. Now, those were done in an effort to drive down a curve. They didn't need to be done even for that purpose, and they certainly wouldn't have needed to be done if we'd had enough effective measures implemented earlier. The irony of this, I'm sure it's something Sinetra will want to comment on, is it looks as though those measures that we had taken earlier, which were quite a lot, we were all being told to stay at home. Schools had already been closed, although I don't think that had much impact, and a lot of else had been done in the lead up to the UK lockdown. And when you look at the evidence, how shall I put this, Sinetra? The statisticians and the modellers are not completely agreed with this, but I would say the direction of travel, in opinion, is firmly towards the view that in the UK, COVID-19 was already under control before the lockdown was implemented. And certainly a lot of the data I've seen is consistent with that. And how? It was brought under control by those earlier measures. Well, why didn't we wait and see if the earlier measures would work? Because the situation had now got rather desperate and people weren't prepared to take the risk of waiting to see if they'd worked. But it turned out they had. So, again, situational awareness. But the bottom line from that last intervention is earlier action can be less drastic intervention.
Thank you.
Good. We'll take lunch now. 1:30, please, everybody. Thank you.
All right.